if there is not enough space. Okay, well, welcome to both of you for the our first Refugee Health Nurses Australia webinar today. Hopefully some more people will be able to join us as we go along. I appreciate everybody's probably quite busy doing their normal clinical stuff, so it's a bit difficult to get away. What we're going to be talking about today is a best practice guideline for immunising refugees in the primary care setting, which has been developed by our service, the Mater Refugee Health Service here in Brisbane, by myself. My name's Meryl Jones. I'm the acting clinical nurse consultant here, and my colleague Anna, who's one of our clinical nurses, and we're both refugee health nurses here. We're both accredited immunisation provider nurses, and both of us have a master's in public health and tropical medicine. So our service is based in Brisbane. We've got two separate arms to the service. The first is the Integrated Refugee Health Service, where we see new humanitarian arrivals. And this co-locates our specialist refugee health nurses in GP practices in areas of high settlement. And they partner there with practice staff to upskill the practice staff, provide support with refugee health assessments, catch up immunisations, and also do some health literacy and health promotion with them. The other arm of our service is the complex care clinic, where I'm actually sat today, and this is a GP clinic based at the Mater Hospital in South Brisbane, and this acts as a GP service for asylum seekers who don't have Medicare, and we also do sort of complex case management for refugees and asylum seekers with sort of more complex medical needs, and we immunise people in both parts of our service. So we developed this guideline for use within our service and also to share throughout the practices, the GP practices that we work with, and throughout the Refugee Health Network of Queensland. But we also thought it'd actually be really exciting to be able to share it with members of RNA in a kind of open source kind of way, to use the collective experience and hive mind of RNA out there to kind of develop it further and make it applicable for across Australia. So at the moment it probably has a slightly more Queensland focus, but we'd be very happy to develop it for a more national audience. So just to give you an overview of the content, hopefully, that we'll be covering today. So I'm going to go through the method that we use to actually develop the guideline, talk about some key messages within the guideline, talk about how to actually get a good immunisation history from patients, how to generate your catch-up schedule, and then go through a bit of a sort of step-by-step guide, and then hopefully some more people will have joined us as well, and we can have a bit of a discussion at the end about, and sort of get feedback from you about what works and doesn't work where you are as well. So the aim of developing this in the first place was so that, hello Jan, welcome. Was to develop an evidence-based guideline that can be used by nurses in a primary care setting, so that could be specialist refugee health nurses, practice nurses, or other immunisation program nurses working in other settings, so whether that's school nurses or nurses working in council clinics or child health or other settings, to provide immunisation to patients of a refugee and asylum seeker background. And we included refugee and asylum seeker background because we wanted it to be applicable for people at all stages of the settlement journey. So whether that's recent humanitarian arrivals, right through to people who've been living in the community for many years. So the method that we used to get our evidence base and develop our guideline was, first of all, we did a literature review, and I'll go through the breakdown of that with you. We interviewed community members from refugee backgrounds. Sorry, Jan, I'm just going to see if I can mute you, just because I'm getting a bit of feedback on the line. We then drafted the guideline based on that literature review and our interviews with community members, and we circulated it to members of our own team, got feedback from them, redrafted, and then sent the revised guideline out to members of our South East Queensland Refugee Health Clinical Advisory Group. Sorry, I'm just having problems with that. So we got further input from the Refugee Health Clinical Advisory Group here. actioned their feedback, and then came up with, well, I've said final document, but as I've said, you know, if we get more feedback at the end of today, then maybe this isn't actually the end at all. So we're very fortunate here at the hospital where our service is based that we actually have a University of Queensland Medical Library on site with some rather fabulous librarians who were able to assist us with our literature search. So we used the PICO approach to develop our inclusion and exclusion criteria for our literature review. So we defined our population as asylum seekers, refugees, culturally and linguistic diverse, migrants and non-English speaking backgrounds. So we sort of threw the net quite wide to begin with. The intervention obviously was immunisation and vaccination. The comparison with the general population in a developed country, and I'll talk a bit more about developed country and why we specifically chose that. And obviously the outcome that we wanted was information about best practice in providing catch-up immunisations and making sure that people were up to date. So there's a list of obviously the kind of articles that we wanted to look at. So going back to the idea of looking at developed countries, because we were looking at providing catch-up immunisation here in Australia, we wanted to look at papers which talked about providing catch-up immunisation in areas or countries of final resettlement. So obviously if you start doing literature searches looking at catch-up immunisation for refugees and you're not that specific, you get a lot of information about you know, mass measles vaccination campaigns in a camp setting, which is not relevant to what we wanted for here. So a lot of the articles we were looking at were either from here or the UK or Germany or the USA or Canada. Due to our own limitations, we wanted articles in English and we didn't put a restriction on the date of publication. So obviously we didn't want to look at the majority population of the country where the articles were published. These are the sort of articles that we also didn't want to include. Obviously, unfortunately, none of us can read languages other than English, so we limited ourselves there, and we only wanted articles that were available in full text. These are the databases that our lovely librarian searched and that we had access to. For those of you particularly into Boolean search terms and mesh headings, those are the ones that we actually used. So at the end of it all, we ended up with 38 documents, and that's the breakdown of what they were. So we read through each one of them to make sure that it actually met inclusion and exclusion criteria, and then after removing duplicates or any that weren't actually suitable, we ended up with 25 at the end of it all. So we took detailed notes on each of those and then organised them according to sort of emerging themes in order to prepare our initial draft. And then we interviewed our community members. So we are really fortunate here in Brisbane that we have the South East Queensland Refugee Health Advisory Group, who are colloquially known as the G11. And this is a picture of, how many, about 7 of them here. So they're a group of 11 consultants who are all health leaders from their own refugee background communities. And they're a really important community engagement mechanism for health service development here in Queensland. And they represent 10 different community groups with the aim of improving health literacy of the broader communities of people from refugee backgrounds. They contribute to health policy development here in Queensland and also improve the capacity of health services to provide appropriate care to people from refugee backgrounds. So I was allowed to go and sit and interview them, and we had present at the interview representatives from Syria, 2 representatives from Iraq, so we had a Muslim lady and a Christian man, a representative from Burundi, from Somalia, from Liberia, from Eritrea, and also from Burma. There was another member from Sudan who couldn't make it on the day, but her views were discussed by a proxy. It was an unstructured interview. We'd already planned our questions, circulated them to the group so they knew what they were going to be asked beforehand. I asked the questions on the day, and the discussion was facilitated by our Community Development Project Officer, Paula Peterson. So these are the questions that we asked them. So they were fairly broad-ranging questions. We wanted to know basically what the opinions and views were out there in the communities about vaccination, what people saw as the barriers and enablers to people actually accessing vaccination, and just anything else that they wanted us to know about how we provide vaccination. I took some very frantic notes during the interview, and then we looked through those afterwards and organised them into themes. So the themes that we came up with at the end of it all were about health literacy, communication and appointments. So overall, every member there reported that their community had a positive view of vaccination, which is encouraging. So around health literacy, it was highlighted by many of the members present that they felt their community had low levels of health literacy, although it should be noted that both the Syrian and Iraqi members said that actually they thought their communities had quite high levels of health literacy. But for those with lower levels, there may actually be no equivalent words for vaccine terminology in community languages. So apparently there's no Tigrinya word for infection or inflammation, I learned. Health professionals need to have an awareness that patients may have alternative understandings or conceptualizations of health in the body. So for example, people may well believe in traditional or spiritual causes of illness. A Liberian community member came up with a beautiful quote, "You can't clean your brain." And then he expanded to sort of explain that what he meant was that when people are learning the Western biomedical model, it takes a while for them to integrate this new knowledge within the context of their original belief system. So there's this transition period. People don't automatically switch over to suddenly understanding germ theory, and we need to be aware of that. With regard to communication, a Somali member said, "If you take the time to explain, I'll tell that to my community." So if we take the time to make sure that we are providing good communication to people, then actually our patients become our best advocates. I was provided with feedback to say that people wanted to know what a vaccine is. They wanted it explained what a vaccine's for, and also what the disease is that the vaccine protects them against. It was also highlighted by several people that they wanted to know why vaccine was being offered to that individual person specifically. So the Liberian, Burundi and Eritrean community members all sort of voiced concerns that their communities wondered why they were being targeted to receive vaccines when they know that some white people refuse to have them. So they felt in a way that they were being singled out. So there's obviously some communication that we need to do around that to normalise it and explain that this is something that is offered to everybody. Now Burmese member said different communities, different way to explain. So we need to make sure that we're using simple, clear language, avoiding jargon, and like I said before, making sure that we know that not all words and concepts are directly translatable, and encouraging questions as well, giving people the opportunity to discuss things further. And finally, with regard to appointment, everybody in the room agreed that they didn't like being rushed, and they didn't like it, well, they didn't like the feeling of being bundled into a room, jabbed and then bundled out with no sort of adequate length of time for the appointment or explanation. And I think it's fairly well known that if you take the time to talk to people and explain, then this helps to build trust and establish good therapeutic relationships. So that was our interview. So then we sort of collated all that feedback and made sure that we tried to reflect that in the document as well, which we then sent out to our nurses within our own team. So as I mentioned before, our nurses in both arms of our service, in the integrated service and the complex care clinic, provide vaccination, and all of our nurses are either immunisation program nurses or they're working towards that qualification. And then when we sent it out to the clinical advisory group, it was reviewed by a GP, practice nurse, the clinical nurse consultant from the Logan Refugee Health Service, Leanne Schmidt, and also the Refugee Health Coordinator from Brisbane South Primary Health Network. So Following review by the stakeholders, we got further recommendations, for example, to send it on to public health to get them to review it. We did send it to public health, but unfortunately haven't actually provided any further feedback at this stage. But, you know, should they do so in the future, we'd be very happy to reflect that on the document as well. So then we put it all together and moved now into the bulk of the document. So first of all, why are we providing catch-up immunisation to refugees and asylum seekers? And the main aim is to provide them with the same level of protection from vaccine preventable diseases as people of an equivalent age born in Australia. So we know that vaccine schedules vary from country to country. So even people who are up to date on an overseas schedule are unlikely to be up to date on the Australian schedule. We know that war and unrest can interrupt vaccine programs overseas, and you know, the literature shows that young children are apparently at most risk for vaccine preventable diseases. And you know, we've seen recently the resurgence of polio in Syria when their vaccination program has been affected by the war there. The literature also showed actually that there were 3 studies from Germany that we looked at where they'd done serology for recently arrived asylum seekers into Germany. They'd looked at their diphtheria, tetanus and polio serology in adults and found that actually there were many people within that cohort who weren't adequately protected. So it shows that protection from immunisation, even for people who have had childhood vaccines, wanes over time. So for adults, they can still benefit from catch-up immunisation. So it's worth offering for adults as well, definitely. So the next key message was that it's important to be opportunistic and to at least start the conversation about vaccination at first contact. So even if you don't start vaccinating people at the first moment you meet them, it's good to at least start the conversation then. Health professionals in, you know, not just literature related to refugees and asylum seekers, but just immunisation in general shows that health professionals are considered a trusted source of information on immunisation. So it's good to make sure that your patients know they can come and discuss it with you at any time. So it's also the responsibility of all healthcare providers. So it's important for us not to assume that somebody else is doing it. If you have a family in the room and you're just immunising one person on the day, it's a good idea to ask everybody in the room about their vaccine history and is there anybody else at home, you know, who hasn't had catch-up vaccine, and being opportunistic in that way as well. And again, the literature says that ideally you should immunise all family members for all vaccines due in one visit where possible. Now, obviously that isn't often possible, and that's going to be that comes back to your communication, your negotiation with the family about explaining to them about things like booster doses and the importance of coming back. So another really important theme that came out of the literature was around documentation. We know that documentation that people bring with them is often missing, or it's incomplete, or it's unclear, or they may just not have any at all. We know that when you ask people their history, their recall isn't always that great, which is fair enough. And throughout the literature, much of it said that you should only use a reliable vaccination history, which we decided to dig more into to find out a good, solid definition of what a reliable vaccination history is. And this was actually defined as a written, dated record of each vaccine or antigen given previously. So in practice, this could include vaccine records from camps, it could include school records, physician records, child health records from overseas, or a detention health summary. So ideally, it's good to be able to many of the records that you may receive will not be translated. Or they will not be in English on arrival. So it's good to be able to translate these. And in fact, our discussion with our community members showed that they felt that patients appreciated it when we take the effort to translate records, because it shows respect for them and trust for them and the medical system that they've come for. So in practice, how do you do this? So ideally, obviously, they should be translated by a qualified medical translator. There are services that you can send records off to. So here within Brisbane, I think this is true nationally as well, you can send records off to translating services via the English language teaching facilities. It's a free service. However, it can take months to have the documents translated, and it's only available to new humanitarian arrivals for their first 2 years in Australia. So quite frankly, if you're doing opportunistic immunisation, in reality, it's not really a very viable option. So alternatively, what can you do? If you have an on-site interpreter, you can ask them to translate the documents for you. If you have a telephone interpreter and your patient is literate in their own language, we've asked our patients to read out the records and have the phone translator translate them for us on the phone. However, if you're using either an on-site or a phone interpreter, make sure that you record their ID and the job number in your medical records. There may be instances even where the patient can translate them. I went on a home visit recently to a family where the mother was a paediatrician who spoke really good English. So although the family's records were in Arabic, I think that, you know, as a paediatrician who speaks really good English, she was perfectly capable of translating those. We would always recommend, though, that you take a scanned copy of the record in the original language and make sure that you've uploaded that into your records as well, so that if there are any queries or discrepancies in the future, you can go back to them. Obviously, there are limitations to doing this with the sort of interpreter or patient translation of records. Sometimes, obviously, not everywhere uses the Gregorian calendar, so you need to make sure you know which calendar is being used, and you may need to translate dates as well as language, if you see what I mean. You must also be very careful not to guess which vaccine has been given based on the antigen. So what you can also do is actually look up individual vaccine schedules country by country on the WHO website, and then, you know, have that in the background to use the reference to assist with your translation. Make sure that you record the route of immunisation where possible. So if polio has been given, was it injected or oral? And be really, really wary with dates. So I'm sure lots of you have found previously that some infant vaccines have been given on a date prior to the child's official or allocated date of birth. So in this case, it's important to discuss with the parents that, yeah, you can record this in the patient's notes, but you can't actually record those vaccines on the Australian Immunisation Register because the computer will say no. So we think that there are two options for you at this point. So option A is that you can't count those vaccines that were given before the official date of birth, or any that aren't adequately spaced as a result of that incorrect date. So those doses will need to be repeated. So you obviously need to discuss this with parents and reassure them that, you know, this shouldn't cause the child any harm if they have repeated doses. Your second option, if the parents are planning to have the child's date of birth officially changed, then you can calculate the catch-up schedule based on the dates recorded. But again, you need to inform parents that you won't be able to record those previous doses on the register until the date of birth is officially changed, so they may have sort of flow-on effects with their Centrelink payments. So if you are going to have to repeat doses or not count doses, then you need to discuss this very sensitively with patients and their families. Explain the risks and benefits of starting the schedule again. Reassure them that repeated doses shouldn't cause harm, and that for adults, evidence shows that the immunity they receive from childhood vaccines probably has waned over time. So actually, it's quite a good opportunity to receive protection over and above that which an Australian-born adult of the same age may have. For children, you know, you can reassure parents that the risk of harm is low, and actually there are some vaccines on the Australian schedule which aren't on the schedule in other countries. So there will be some vaccines that they're offered here which they won't previously have had access to. So for example, although the Syrian and Iraqi schedules are very similar to the Australian schedule, I haven't seen any children arriving from there so far who've had mense or varicella. So yeah, if you have a patient who has no documentation, basically they're considered unimmunised. But again, you know, you need to be having that conversation with them about how it shouldn't cause them harm to be repeating vaccines. If they don't have documentation with them, but they say, no, I've definitely got it, I've got it somewhere, then try and help them to find it. So, you know, first of all, remind them to bring it next time. You can look on air. You can request an immunisation summary from a previous GP or healthcare provider. So when you're looking for those documents, so looking for vaccines that are being given pre-arrival, you can look on the Health Manifest or Settlement Report. If you don't have a copy of that, you can request one from the Department of Immigration and Border Protection. People who have been in either on or offshore detention should have been provided with a detention health summary or discharge health assessment, which should have their vaccination on them, or the ones that were given in detention. Obviously, sometimes these get lost or people haven't been given them. If people are in community detention, we've been told by IHMS you can call this number and request the information. If they're in offshore detention, apparently if you send a signed by the patient request for release of information to this email address, they should provide you with it. In reality, I have never, this is the information I was given by IHMS. I've never actually managed to access records this way, but we're in discussion with IHMS at the moment to resolve this. So I'm interested to hear back from RNA members about, you know, what success you've had with this process. And also when I hear more from IHMS as well, I'm happy to circulate that to the group so that we can share that information as well. So for vaccines given after arrival in Australia, obviously people may have their own handheld records. If they've moved from another state or territory, then they may have those records. Obviously you can look on the Australian Immunisation Register, or here in Queensland we have VIVAS as well. And also, like I said, you can request records from previous primary healthcare providers, so previous GPs. So when you've got all this information, you would like, it's ideal to record it in the practice software if you're working in a GP practice, recording the type of vaccine, so give the name that's recorded. So if it says Priorix, then enter Priorix. If it just says MMR, then just enter MMR and don't put MMR2 or Priorix, although this will depend on the software that you're working with. Record the dose number, the date that it was given, and if you've got it, record the batch number, because obviously this is all important for management of vaccine surveillance and adverse events after immunisation. Once you've got that history as well, send it off to the Australian Immunisation Register so that previously given vaccines can be registered as well, which will help, you know, if people move down the track. And then you're going to develop your catch-up schedule based on the age of the patient. If you are working with somebody who has started their catch-up schedule when they arrived 5 years ago and then they moved and, you know, hasn't continued, there is no need, according to the literature, to repeat any doses or restart the schedule. You just continue from that point on. So specific factors that you should be considering also when you're looking at your immunisation history and developing your schedule is the age of the patient and any licensing or funding restrictions that may apply. So for example, MMRV is only licensed for people up to 14 years of age. But young people up to 19 years old may also be funded to receive varicella vaccine. You need to look at any sort of recent or schedule changes that are planned. So obviously we had Infamrix introduced at 18 months last year, and Zostavax, and here in Queensland, maybe elsewhere as well, they're going to be introducing MenA-CWY quite soon. You also need to look at how your schedule is going to interact with other vaccination episodes. So if it's a child who is likely to be offered school-based vaccination in the next year or so, you need to think about how it's going to interact with that. And in this instance, it's probably worth discussing with parents that your child is going to be offered vaccination through school, but they can also come and receive them at the GP, because I imagine that there are probably problems with people being sent home letters in bags that they can't read and expected to sign consent forms. So it's probably a good opportunity to discuss this with parents. Ideally, we want to minimise the number of needles that people are having and the number of visits, so using combination vaccines. And if there are lots of vaccines to be given at one time and people are particularly resistant to the idea of having multiple needles at one time, you may need to sort of negotiate with them and consider things like whether there are pregnant women, infants or elderly in the family, whether there are any local outbreaks. You know, have you got an outbreak of meningococcal C or measles going on at the time, and prioritising based on that. And just finally, a quick note about funding. So refugee vaccines are state funded, not federally funded. So you need to check which vaccines are funded for refugees in your state or territory. Catch-up vaccines for children up to the age of 10 are funded for all children. Catch-up vaccines for children aged 10 to 19 years are funded for those who receive family assistance payments. And then for adults, it will be different, I believe, depending on where you are. So once you've got your beautiful history, then you want to actually tailor the schedule for your individual patient. So to do that, you need to consider the relevant clinical information pertaining to your patient. So are they pregnant, in which case you want to offer vaccines recommended during pregnancy at the correct gestational age, but also discuss with them the need for catch-up schedule to be commenced as soon as possible postpartum. If your patient is over 65, they may be eligible for additional vaccines like pneumococcal. Sorry, I've got a bit of echo on the line. So pneumococcal or Zostavax. If your patient has HIV or is otherwise immunocompromised, with their specialist. Sorry. Hello, Kay. So also the Australian Immunisation Handbook gives very clear guidance on things like CD4 count and whether or not to give live vaccines. So always refer to that and the patient specialist if they have one. It's also worth thinking about asplenic patients as well. So whether your patient is asplenic for whatever reason, whether it's infarct from having sickle cell or an MVA or anything else. If you're in Victoria, Queensland or Tasmania, you can register your asplenic patient with Spleen Australia, and they will provide additional guidance and information on the optimal timing of vaccine administration and any additional vaccines required. Being asplenic puts you at higher risk of infection from encapsulated bacteria, so pneumococcal and MenB, so the new Bexsero are recommended for them, although you're probably going to need to check about funding for those patients. Obviously, flu vaccine for some people, and also people with liver problems should, you should be considering giving them Hep B vaccine. So we looked at the ACID guidelines around serology and using that to guide your schedule. In general, ACID does not recommend routine serology against all vaccine or for all vaccine preventable diseases to guide your catch-up. However, it does recommend serology for a couple of things. So first of all, for Hep B, for refugees from countries where Hep B is endemic or highly endemic, which actually is most countries of refugee origin, and secondly, those at high risk of acquiring Hep B. It recommends pathology screening for varicella for refugees over 14 years of age with no history of natural infection. Again, you may need to consider funding because it's all very well finding out that your 20-year-old patient isn't immune to varicella, but if they're not funded to receive the vaccine, then you're going to have to weigh up whether or not, what you're going to do with that information. They also recommend doing rubella serology for women of childbearing age. Again, as MMR is part of the funded catch-up schedule and single rubella isn't, unless you're also checking measles and mumps serology, which ACID don't recommend, then again, I'm not sure how much sort of worth that individual rubella result is. So you probably need to have a think about that as well. So we generally don't check rubella serology because we give everybody MMR vaccine if it's indicated. So again, you're going to need to consider any doses that were given before the child's official date of birth. So often we see polio given before day 28 of life, which won't be counted, and anything that isn't adequately spaced in line with the Australian National Immunisation Programme. So again, often we see Hep B doses that haven't been spaced adequately according to our schedule, so those vaccines may need to be repeated. So again, you need to have that conversation with your patient as to why they're getting a repeat dose of something that they think they've completed the course for. So just a quick bit around the intervals required for optimal immunity. So the Australian Immunisation Handbook is your source of truth on this. Inadequately spaced doses will need to be repeated, and if you don't, then obviously the doses may not be effective, which is your main concern, but also it can affect families' Centrelink payments under No Jab, No Pay, which I'm sure you're all very well versed in at the moment. Live vaccines should be spaced by at least 4 weeks. The interval between your Hep B doses is strictly laid out in the handbook as well. We often use the South Australian catch-up calculator to check the intervals of the doses previously given. Now, we would suggest that it's best practice to calculate your own schedule, but to use the South Australian catch-up calculator as a kind of a good second checker, if you like. Now, currently, I believe it only covers birth to 19 years, and it is highlighted throughout the literature that it would be ideal to have a whole of life calculator, although sadly that's not available yet. So moving on to our sort of step-by-step guide. So first of all, always follow your handbook, your health management protocol, and whatever other local policies and protocols and procedures you've got. I'm sure I'm preaching to the converted here, but always use professional interpreters. Now, if you are providing immunisation under the orders of a GP in general practice, you can use the GP's TIS code to access a free medical interpreter. We should be using interpreters to get history, to get informed consent, and to provide pre- and post-immunisation advice and documenting that we've done that. It's also best practice to document the language of the patient and the interpreter service job number or the interpreter's ID in the patient's record. We should be discussing risks, benefits and potential side effects, and this was something that our community members sort of stressed that they really wanted to hear about. Interestingly, one of our Iraqi members wondered about additional vaccines available in Australia which weren't on the Iraqi schedule, and she thought this might be because they were increased risk of diseases here. So the example she gave was Gardasil vaccine, and she said, oh well, we think that we're offered Gardasil because we're at increased risk of HPV here and we weren't back home. So there are some interesting issues that probably need, are worth exploring and discussing with patients. And again, within the Iraqi community, there was sort of concern about why adults needed revaccinating when they'd had vaccines previously. You need to make sure the information that you give people is obviously in the right language and also pitched at the right literacy level. There are lots and lots of written and audio visual resources out there. Refugee Health Network Queensland has a YouTube channel which has some videos on it, and I think previously we've had some talking books with vaccine information from New South Wales as well. So those resources are out there and you may have to source them, but they do exist and they're very useful. Make sure that you actually discuss the catch-up schedule that you've developed, offer a copy to the patient, and also talk to them about the importance of finishing the schedule and why there is a need for multiple or booster doses, because people may not appreciate why, if I've had one Hep B vaccine, why do I need to come back for another 2? It's also important to consider local protocols for identification and procedure matching as well. So consider using things like name bands or stickers for large families. We once went to do a home visit to vaccinate a large family where 3 of the boys in the family were about a year apart from each other in age. They were all wearing the same jumper and they all had really similar names. So we ended up putting stickers on everybody, name stickers on everybody in the family, sitting each person down in the chair one by one, asking them what their name was, and then asking at least another 2 people in the room to identify them as well. So sometimes you need to be a bit creative about this to make sure that you're giving the right person the right vaccine. And again, reflecting this in your notes as well, so making sure lots of the software packages like MD and best practice use in GP practices will have sort of pre-filled texts that you can use to make sure that you can just drop that in nice and easily. Before the patient goes, make their next appointment. So if they're due to come back for the next vaccine in 1 month's time, then make the appointment for them before they leave. Where possible, use things like phone or text reminders. Consider transport options, liaise with the settlement agency to make sure that the appointment you've made isn't going to clash with their Centrelink appointment, because they're going to go to that instead of come back. Or, make sure that if you're making appointments ideally on a TAFE-free day, or maybe sort of after school time if they're very concerned about the children missing school. And also trying to align vaccine visits with other visits. So if they're coming back to see the GP in a month's time, then make the vaccine appointment for the time they're coming to see the GP anyway, so you're not constantly dragging them in for extra appointments. Many of the practices that we work with here in Brisbane use the New South Wales translated appointment tool, which is really good. I've got a link for that at the end. Make sure that you give people adequate time for the vaccine visits, and if you're working in general practice or whatever your primary healthcare setting, make sure that you actually allocate the right amount of time. We generally give about half an hour to each adult, or sort of half an hour for the first 2 people and about 15 minutes for all subsequent members of the family. And we find that even in second and third vaccine visits can be quite time consuming. However, it's also a really good opportunity for health promotion and health literacy education. We encourage people to try and stick with the same immunisation provider to complete the schedule where possible, just to promote that continuity of care and making sure that the vaccine history doesn't get fragmented. And recording all vaccines on the Australian Immunisation Register. Now that we have this lovely whole of life register, making sure that you put your adult and your children's vaccines on there, including those given pre-arrival if you've got that history. Feedback that we got from our sort of other providers, our stakeholders, was that you should give a printout of all the vaccines given after each episode. So after each episode that you vaccinate somebody, give them a handheld history of everything that they've had to date. Ideally using the standard format for the area that you're in. So if they've got a child health record, a red book or a blue book, you can write them in there, or a printout from the practice software or a little card. Encourage them to bring it to each vaccine visit, and also tell them to keep it with their important documents like their passport, and also talk to them about when they might need to show the record again. So they might need it for school or daycare enrolment, or even for a job application in the future. And also let them know that if they lose it, that's fine. They can come back to you and get another copy at any time in the future. Now, we also had quite a lot of discussion with our stakeholders here about how frequently to transmit vaccination data to the Australian Immunisation Register. The practice nurse and the Refugee Health Service down in Logan recommended daily transmission of data. And this was because it takes several weeks for vaccines to be recorded on air. And obviously this can impact on Centrelink payments. So their recommendation was daily. You probably need to have a think about, how that works for your service, but that was the recommendation that we were given. And then, tell people at some point in the future they may well want to go on holiday, they may want to go back and visit family. So discussing with them that if in the future they are going to do that, come back and have a chat to you about travel vaccines as well, because they may need more vaccines in the future. So just some more information before we get to questions. So I'm happy to circulate all these links so you don't have to scribble anything now, but basically Refugee Health Network Queensland, the Victorian Refugee Health Network and the New South Wales Refugee Health Service have all got lots of information. I mentioned the South Australian catch-up calculator and the appointment reminder translation tool, which are excellent. And we find really practical and helpful. And there's also the Community Immunity Immunisation resource, which is out there. and I apologise. This is actually a link to a poster that we presented on this at the APNA conference on the weekend. So now what I will try and do actually is unmute everybody and actually invite feedback, hopefully. This is where it gets technical and difficult. I apologise. Okay, can anybody talk back to me at this point and tell me that you can hear me?
Hi, Meryl.
Hi, Meryl. Hi, Meryl. Hi, Meryl.
Hello, is that Jan?
Yeah, that was pretty unpleasant. Did you hear all the
You were very echoey.
Very loud. Yeah, that was great. Well done. One of the questions I just want to go on.
Yeah, no, carry on. What questions do you have? I promise I'll be able to answer them.
About patient consent. Was there anything in the literature or in your process about clients recording client consent or guardian consent for administration of vaccines? It's something that we do. I just wonder if it came into the literature at all.
It wasn't specifically mentioned in the literature as a sort of recommended process to go through, just as really as you would do for anybody. So talking about risks and benefits and potential side effects and documenting that you have done that, documenting that you've got patient consent, and also documenting, you know, interpreter use when you've needed to do that, obviously, and that if you need an interpreter, you should be using one. So there was nothing
in the. I thought it was in the immunisation handbook. Is all. That's all. I can double check.
Yeah, I would need to go back and have a look. I don't think there was anything special or different, if you like, for refugees than there would be for anybody else. But certainly, it's your sort of standard stuff about interpreter use and risks and benefits. And again, what we've done is developed a little sort of pre-filled text that we use to just sort of make sure that it's a sort of checklist reminder for us to make sure that we've spoken to everybody about these things. And also then we drop that into the practice software or whatever we're using to make sure that we've documented that we've said all of those things as well, so that we are recording informed consent properly.
Yep, great.
Does anybody have any experience of requesting records from IHMS? Has anybody had any success with getting records from people who've been in community detention or offshore detention and didn't have a health summary?
No, not for us here in Western Australia.
Yeah, no, that's, yeah.
Okay, so like I said, I actually spoke to or have been put in touch with somebody from IHMS who deals with their immunisations recently. Now, I was told that I was under the impression that they had never recorded any of their the immunisations that they gave on what was ACER at the time, but apparently sometimes they did. So it's probably worth a look on AIR or ACER to see if anything is on there. I haven't found any instances where it has been, but it's probably worth a look. And also, like I say, when we get a better process from them, I'm very happy to circulate that to the group, because that's something that we've struggled with previously, and it sounds like maybe that's been an issue for other people as well.
Can you hear me there?
Yes. Hello. What is your
Hello.
name? Where are you from?
My name's Alex Truelove, and I'm one of the refugee nurses in Perth, Western Australia.
Oh, hi.
Hello. I've just got a question around, you were talking about the calendars, and we use the, I think it's called the Islamic Chamber Society to translate put in the dates to get from Islamic calendar into our calendar, and I just was interested to know whether there were any other online references or translation tools that people are using.
To be honest, I've only had to do it once, and apparently there is more than one Islamic calendar. So in this instance, it was actually some records that were from Afghanistan, and it just happened that I had an on-site interpreter, and the father of the family whose records they were had also been an English translator in Afghanistan. So they were telling me that there are a number of different Islamic calendars. So we had to go and I think we Googled it, which is probably more of a practical approach, sort of on-the-fly approach than a sort of recommended approach. So if you wanted to send the link to the calendar translator that you're using to the Refugee Nurse Australia Gmail account, I'm happy to circulate that out to the group as well, if that's one that you found to be useful and reliable.
Sure. Yep, we can do that for sure.
Great, thank you.
We're very fortunate to have an Arabic-speaking doctor who works alongside our department, and so he put us in touch with that.
Oh, okay, fantastic. Yeah, we also are quite lucky to have some Arabic-speaking GPs, and in fact I didn't include those, but you know, obviously you may have doctors or nurses within your own service who are able to do that job, so that's also a good practical approach. So I have to say we initially thought, oh, well, we should send everything to the you know, this proper translation place at the English language at TAFE, and then found out that it was going to take 2 months, and it was only for people within the first 2 years, and it's just not practical, especially when you're trying to do opportunistic immunisation. So while it was a brilliant idea, in reality it just wasn't going to work for us. So, and I think that's the thing with all of this, there's the ideal and then there's reality, and we have to try and find the most workable, you know, the best practice, but also the most workable practice that falls probably somewhere in between that. Did anybody else have any comments or suggestions or help that they'd like to provide to the rest of the group? If there's anybody else who I can unmute, actually. I can see Lisa's here.
You mentioned something about YouTube channel for Queensland, produced by Queensland Health about vaccines. What languages are those in?
Okay, so again, I'll send around all these links. So the Refugee Health Network of Queensland has a YouTube channel on which are videos in different community languages. There are different sort of videos on different topics for different community groups, so we don't have the full load of topics for all languages. Certainly I know we've got something on vaccination in Juba Arabic and a couple of other languages as well. So I can send around the link to that, and you can have a look on there and see. It's a more broad discussion about what immunisation is and why people are offered catch-up vaccination, rather than a kind of step-by-step, hello, you're here for vaccination today, what does that entail? But I know there are others out there as well, and in fact we've got a resource coordinator here who actually puts together a lot of, like, tries to collate a lot of this information and is trying to disseminate it through the Refugee Health Network Queensland website, which has a resource section on it. So that's a good place to go and look. So yeah, I'll make sure I've sent out all those links to everybody so you can have a look.
Okay, yep.
Does anybody else have any? Yeah?
On that topic, I was just interested to just, given that we're all in one space together, in reference to what you were talking about regarding health literacy and the importance of using and providing information to clients in their language, we've been doing a bit of work in terms of trying to build our database of multilingual resources, and we draw on things from all around Australia, all different websites, from different states as well. I was just interested to know if everybody else is doing the same thing.
Sorry, where are you from?
So we're from so from Perth, so we're working within the Humanitarian Entrant Health Service here in Perth, and we're just looking at building our resources within WA, but obviously not wanting to duplicate. And there's obviously quite a vast array of health resources online already. So I was just interested to know whether there is what other people are doing in other states regarding that, because we've been looking at getting projects, to sort of increase and pool things in this area so that there's sort of one database that we can use across health services.
Okay, I can answer from Queensland. So our refugee health network here in Queensland, we have a resource coordinator who is also doing that. So if you want to, email Refugee Nurses Australia, and I can put you in touch with Ali, who's our resource coordinator. What are people doing in other states? Does there anybody want to comment on that from anywhere else?
Hi, I'm Jen from Wagga. I'm not actually a refugee health nurse, I'm a project officer, and a part of my role is actually developing a resource folder to go out into the acute and community health settings, and I've got a series of resources that I've gleaned off the web and used the New South Wales Refugee Health Network as well, who have been very helpful. But there is a website called Health Translations, and that is, you may already know about it, and that holds pretty much all translated documents in a variety of different languages and subjects, and you just type in what you want to know and it'll come up whether it's got the language or not. Is that what you're asking about?
Yes, it is. Yeah, and we do use that. We've got, as I say, we've got quite an array of, we draw on that, and New South Wales Multicultural Health website as well. I just was really just filling in the gaps. I was just interested to know what's happening in other states.
Yeah, so I'm happy if people want to email the RNA Gmail address. I can put you in touch with, well, I mean, basically I'm happy to sort of collate all that and then sort of send it out to individual state representatives, if you like, so that we can try and sort of, I guess, streamline that, work better together and stop sort of unnecessary duplication, because it sounds like we're all trying to do the same thing and we're all trying to look at the same resources, so we should be able to work together and pool them, I would have thought.
Yeah, I think it's a really good opportunity.
I think the other thing that's happening at a national level is the online version of the Promoting Refugee Health practice tool that Foundation House is leading with. So
this is the new desktop guide?
Yes, yes. So that'll be version, and each state and territory will have their own sort of local based version of that, a web page to fill in, but that will kind of link to various online resources as well. So there's an attempt to kind of make that available at a more of a national level. So I think that's useful to bear in mind, that when that's finished it'll be a good platform, because not every state has a refugee health website, or every health service. Like in South Australia, we don't have a website at the Migrant Health Service. So as much as we'd love to have a central place where all those links were kept, we don't have it. The best that we've come up with, yeah, go on.
Yeah, I was just going to say, again, it always comes down to funding and, our time, and
yeah.
So this is often something that's done sort of, in and around patient clinics, but if we could be working together across state, and if there would be one place online that we could all be contributing, it would make so much sense.
Yeah, great.
Yeah. Well, I think that, I think that national guide will be a good place for that.
All right, so did anybody have any other particular burning issues at the moment, or otherwise I might wrap it up, but just to throw it out, if there's anything else that anybody wanted to discuss or ask or feedback at this stage? No?
No, but thank you. That was great. Very comprehensive.
That's
Yeah, no,
fine.
thanks,
So
Meryl.
the guideline is on the Refugee Health Network Queensland webpage. Like I say, I will send out to all of the RNA members the links to some of the web pages that we've discussed, and also to the guideline and the poster that accompanies it as well, so everybody's got that. Now, this has been recorded. I have no idea where it's actually whether it's being held or what we'll be able to do with it in the future, because this is actually being facilitated by the Victorian Refugee Health Network. So hopefully people will be able to access this in the future, but otherwise I will definitely send out all the resources to everybody so we can all use them. And otherwise, thank you so much for attending, and I look forward to hearing from you all in the future. Thank you very much.
Thanks, Meryl.